My name is Vanessa, and today I will be presenting my research regarding telemedicine benefits and challenges in rural and remote pediatric cardiology. This research was completed during my master's education at Laurentian University and was co-authored by Dr. Nancy Lightfoot and Dr. Emily Donato. So for some background, congenital heart disease, or CHD, refers to a defect in the heart structure that is present at birth, and it is characterized by complex care, close monitoring, and significantly compromised quality of life. The type of treatment for CHD depends on the severity of the condition. For critical or major conditions, which are the most common, immediate treatment upon diagnosis is necessary for survival. The rate of infants born with a CHD in Canada per 10,000 births increased by 1.4% between 2006 and 2020, and more than half of those diagnosed with CHD require surgery to survive, 40% of which are less than 1 year old. The CHD hospitalization rate continues to rise, which is evident by the increasing cost of hospitalizations in Canada due to CHD. The rate of hospitalizations increased 21.6% between 2004 and 2013, and majority of these were for children compared to adults with the same conditions. The high prevalence and costs of CHD encounters suggests the need to focus on ways to better manage these conditions among children. The problem is that not all children and infants with CHD are impacted equally. Northern, rural, and remote communities are characterized by limited access to healthcare services and cardiovascular specialists, and greater exposure to environmental hazards. In fact, less than 2% of Canadian specialists practice in rural areas, despite 18% of the population living in rural areas. While there are 15 CHD centers across Canada, represented by the purple dots in this map on the left, as we can see, they're largely based in urban areas, represented in red, which means that children in rural and remote areas must travel long distances to receive the care that they need. The result is that these children experience inferior health outcomes, delayed diagnoses and treatment, financial and social strain, and unnecessary transportation. So telemedicine offers a potential solution to this problem. The WHO defines telemedicine as the delivery of healthcare services where distance is a critical factor, using information and communication technologies in the interest of advancing the health of individuals and their communities. In practice, telecardiology, which is the use of telemedicine in cardiology care, can involve a patient visiting a local primary care center where they will be connected with a cardiologist at a distant site via telemedicine, or alternatively, a patient can be directly connected with a cardiologist using telemedicine from within their own home. The literature reports numerous benefits and drawbacks of the broad application of telemedicine. However, in Canada, and especially in rural and remote communities, telemedicine services are not sufficiently established, with no widely accepted frameworks currently available in the literature. The formal research question was to assess the social, financial, and health system impacts, as well as patient and caregiver perceptions and experiences of telemedicine in improving A, access to care, and B, health outcomes for pediatric cardiology patients in northern, rural, and remote areas of Canada. So overall, this literature review aimed to better understand the effectiveness of telemedicine in rural and remote settings, to inform health policy and contribute to the development of a telemedicine framework. The theory of access proposed by Pinchansky and Thomas in 1981 was used to guide this research. And this theory defines access to healthcare as the fit between the patient and their caregivers and healthcare services, in this case, telecardiology. The theory holds that these 5 key variables on the right, so availability, accessibility, accommodation, acceptability, and affordability, must be met in order for individuals to effectively utilize healthcare services. So I'll now briefly discuss the methods of this literature review. So the integrative review methodology put forward by Whitmore and Naffel in 2005 was used because it allowed for a more rigorous approach to a literature review. It involved 5 stages. So the first was to identify the problem, followed by the literature search, data evaluation, and importantly, data analysis, which involved 4 stages: data reduction, display, comparison, and then conclusion drawing. And then to finalize, all the data was presented in a table format. Studies were first screened by title and abstract, then by full article review, and this process yielded 35 articles that met inclusion criteria, the majority of which were quantitative studies and conducted in the United States. Only 4 studies came from Canada. However, all studies focused on a rural or remote population. Once all studies were screened for inclusion and assessed for quality, data was extracted and organized using this table format. So each article was organized by author, year and country, design, purpose, sample, and results. And then to analyze the data, 7 critical questions were developed based on the key objectives of the study. So here's a sample entry with the key questions being the type of telemedicine considered, if technology was effective, patient and caregiver experiences, provider experiences, costs, benefits, and barriers. After entering all the studies, subgroups, themes, and patterns within each critical question were identified, noting any gaps, similarities, or inconsistencies in the literature. Thematic coding was then conducted for each type of evidence with codes grouped into categories to draw a conclusion. And then finally, the themes and conclusions derived were validated with primary source data to ensure accuracy and confirmability. Journaling was also completed for high-level analysis and to provide an audit trail. So now moving into the discussion of the findings. This was organized according to the 5 variables of Pinchansky and Thomas's theory of access. When it came to availability, in all of the studies included in this review that used telecardiology, patients in underserved areas had access to the resources required for efficient clinical decision-making. However, the high cost of establishing and maintaining these resources remained a significant challenge. In Canada specifically, there is a patchwork of telemedicine policies and programs across provinces and territories, and there's no consistent funding model for pediatric telecardiology initiatives. So this inconsistency results in uneven resource allocation, potentially limiting services in northern, rural, and remote areas across the country. Provider licensure discrepancies also hinder the availability of clinicians in rural and remote areas. Regulations vary among provinces and territories with registration for non-jurisdictional healthcare providers differing, and there are certain exceptions in certain provinces. So there's not really any consistency. Also, the high fees and difficult application requirements for physicians seeking licenses outside their home province creates obstacles for rural practices, threatening their viability. As part of a solution to these issues, the Canadian Medical Association has long advocated for a pan-Canadian licensure, which was supported by 91% of physicians in a 2019 survey. While it has not yet been implemented, some steps have been taken to address physician shortages in rural areas. So for example, the Atlantic provinces launched an Atlantic Physician Register, which allowed physicians to practice across all 4 provinces without additional licensing, removing that barrier to patients receiving care from healthcare providers. In terms of accessibility, the literature largely suggests that telecardiology reduces the geographical barriers to accessing specialist services. However, a critical factor was the inequities in access to reliable internet in rural and remote areas. In Canada, there exists an urban-rural divide and access to high-speed internet and cellular connectivity. The development of broadband infrastructure in rural areas of Canada has been significantly slower, which is attributed to many things. One of which is the lack of a comprehensive federal broadband policy, as well as greater emphasis on promoting the growth of private sector initiatives. So that is really an issue to ensuring that telemedicine is available in rural and remote communities. Inuit First Nations and Métis communities also continue to have significantly limited access to digital connectivity with higher operating costs, service costs, and data overage fees. Efforts to narrow the digital divide in rural and remote communities, particularly within Indigenous communities, are vital for ensuring equitable healthcare access. In any initiative, leaders from affected communities must engage in policy decisions regarding how digital connectivity is established and managed, And when doing so, First Nations communities must have ownership and control over their infrastructure. To effectively deliver healthcare services, patients' needs, constraints, and preferences must, of course, be accommodated. The results of this literature review suggest that both pediatric cardiology patients and their families and caregivers were highly satisfied with the delivery of specialty care via telemedicine. For patients residing in rural and remote areas, it is imperative that when receiving care from specialists who have received training and practice in urban areas, a needs assessment is conducted to ensure that the care provided is tailored to their specific circumstances. In the literature, rural physicians really highlighted the urban consultants' lack of familiarity with with rural patients' social context and the impact of patient transfers on families. Interprofessional communication and continuing education were found to be essential for urban physicians to understand the contextual factors in rural and remote areas. To meet patient needs, telecardiology must also consider the child friendliness of technology and provide language services, especially for newcomer, francophone, and indigenous communities. Integrating these factors into telemedicine programs ensures both accessibility and accommodation, really leading to improved health outcomes and higher patient satisfaction. In terms of affordability, implementing pediatric telecardiology in rural areas requires a significant initial investment, primarily borne by healthcare systems. Nonetheless, the literature suggests this upfront cost yields substantial long-term savings and improved healthcare access. Over time, telemedicine tends to result in cost savings for the healthcare system by optimizing resource use, reducing unnecessary hospital visits, and shortening hospital stays. When addressing the affordability of telecardiology services for patients, it's crucial to account for the expenses associated with in-home technology and devices. In Canada, coverage for these devices is contingent on the provincial and territory health insurance plans, so there's really no consistency. The financial implications for initial and ongoing connectivity expenses should also be a central consideration. It may be necessary to explore strategies for providing subsidies or assistance to families facing financial constraints. Collaborations with telecommunications companies or government initiatives aimed at improving internet accessibility in rural and remote areas would also alleviate this burden. And now finally, for acceptability, the studies in this review largely suggested that patients and caregivers did find value in telecardiology, feeling that their needs were ultimately met. That said, they commonly express that telecardiology should not entirely replace in-person, face-to-face visits. So a potential approach could involve specialists visiting rural clinics regularly to conduct in-person visits alongside telecardiology. The patient-provider relationship is also important in telecardiology, given the lack of a physical presence. So to ensure comfort, trust, and understanding, patients should ideally receive care from the same specialist each time to really promote continuity of care and ensure that providers are familiar with their patients' needs and preferences. For Indigenous people in northern rural and remote areas, developing a trusting patient-provider relationship is particularly important due to damaging historical and ongoing relationships with the state. Non-Indigenous specialists providing telecardiology care to Indigenous communities must prioritize cultural safety and awareness, engage in anti-oppressive and anti-colonial education, and really focus on building a foundation of respect and trust. So looking at the implications of this literature review, there are several. For one, it identified gaps in the literature that require further empirical research. Particularly, more qualitative studies are needed to explore and better understand patient and caregiver experiences. A lot of the studies I included were quantitative in nature. Another potential research area is an economic evaluation of the impact of pediatric telecardiology in a northern, rural, and remote Canadian context specifically, as not many studies in the literature have done this. And it's important to have a societal perspective that accounts for the implications on total welfare, because there are so many different variables to understand here. or consider here, sorry. The results of this integrative review may also help guide the development of a framework for the implementation of telemedicine in rural and remote communities. It can also help policymakers make informed decisions regarding the integration and regulation of telemedicine services. Based on the results of this review, for future policies and legislation must focus on universal physician licensure, billing, and provider reimbursement, as well as ensuring the availability of necessary resources and technological infrastructure to support telemedicine in rural and remote areas. And here are my very many references. And that's all I have for today. I welcome any questions. My email and my LinkedIn are also here if you'd like to reach out after the fact.